Our team's topic is electroconvulsive therapy, so first, let's talk about the definition. Following the New South Wales Health Department guidelines, electroconvulsive therapy, or ECT, is a form of treatment popularised in the 1950s for alleviating the symptoms of severe mental illness, and which is seeing a resurgence of use in modern medicine. During treatment, an electric current is delivered to the brain to induce a bilateral generalised seizure. There are two types of waves that have been used when administering electroconvulsive therapy: sine waves and brief pulse, with an additional two subtypes of partial sine wave and ultra brief pulse. These four waveforms vary in intensity and time of duration. Electroconvulsive therapy is recommended for patients aged 13 years and over who suffer from treatment-resistant major depressive disorder, catatonia, schizophrenia, bipolar disorder, food refusal with severe nutritional compromise, or severe suicidality. A modern ECT device will have a constant current, bidirectional brief pulse square wave output, a method of measuring circuit impedance, a safety mechanism for the treatment button to prevent accidental discharge, be capable of delivering a charge of at least 1000 millicoulombs, and be capable of delivering a variety of stimulus parameters. There are also a number of additional accessories attached to or required for the use of an ECT device, including the headpiece or treating electrodes with a minimum diameter of 5 cm to avoid burns, an appropriate conductive gel or solution, and a mouth gag to prevent the patient biting their tongue during treatment. The electroconvulsive device was developed in 1938 and was originally contained in a wooden cabinet. A cloth was used to cover the electrode, and both handles were also made from wood for electric resistance and were attached with wires. ECT was initially administered while the patient was fully conscious and without muscle relaxants or anaesthesia. Thus, seizure occurred with a full-scale convulsion. This resulted in the rare but serious complication of long bone fracture and dislocation. Additionally, cognitive side effects including confusion and retrograde amnesia were frequently experienced by patients following treatment, with memory disturbances ranging from days to months prior. In the 1940s, psychiatrists began to experiment with muscle paralysis during treatment in order to reduce convulsions and improve patient comfort. A short-acting anaesthesia was given in addition to a muscle relaxant to render the patient unconscious. The first muscle relaxant used was curare, which is derived from a South American poison. It was later replaced by suxamethonium, which is not only much safer, but is also favoured for its short duration of action. From the 1950s to the 1970s, the use of ECT was significantly reduced due to the negative impact of popular media. In addition to articles in the New York Times, widespread public concerns arose after the release of the 1975 film One Flew Over the Cuckoo's Nest, during which electroconvulsive therapy was used as a punishment for an uncontrollable subject, and the treatment was depicted as extremely frightening, dangerous, and inhumane. There have been several subsequent depictions of electroconvulsive therapy being used to control difficult patients in a manner that would today be deemed unethical. However, despite the negative media, ECT remains successful in alleviating symptoms in patients with treatment-resistant mental illnesses. Since ECT was first introduced, clinicians have made many modifications to improve the efficacy and safety of this treatment. This includes developments in pulse width, dosing and duration, and electrode placement. Most ECT devices used today feature a constant current output stimulator that allows continuous current regulation. Pulse width is a commonly altered waveform parameter in ECT delivery. Most research supports administering repeated brief or ultra-brief pulses from 0.5 to 2 milliseconds, which is associated with a greater charge efficiency and fewer side effects than traditional sine wave dosing. Using a brief or ultra-brief pulse width achieves this by focusing the stimulus on the brain regions that regulate mood, while limiting stimulation of brain regions involved in cognitive functioning. In terms of clinical efficacy, how much the electrical stimulus exceeds a patient's seizure threshold, i.e. the minimum amount of electrical charge that induces a generalized seizure, is more important than the absolute intensity of the stimulus. Acute therapy patients typically receive 2 to 3 treatments each week, culminating in 12 to 18 treatments. The optimum number of sessions administered is determined by the ratio of clinical improvement to the severity of the adverse cognitive effects. Spatial targeting of stimulus is crucial to maximize therapeutic benefits and minimize side effects. Concerns about cognitive side effects have led to variations in electrode placement to minimize the amount of brain parenchyma affected by electrical discharge. These include bitemporal electrodes, which are placed on the midline between the eye and the ear on both sides of the head, and right unilateral electrodes, in which one electrode is placed lateral to the vertex and the other at the right temple. These developments have allowed electroconvulsive therapy to continue to be a relevant and effective treatment for several mental illnesses.